Welcome to the deep dive. Today we're going to try and get to grips with one of the toughest areas of professionalism. We're breaking down the GMC's professional duty of candor into simple, high-scoring principles for anyone revising for the MSRA SJT.
Yeah, and this topic, it's particularly challenging. I think it's because it mixes that high emotional stress of when something goes wrong with the very rigid professional standards the GMC expects.
Absolutely. Let's just jump straight into that pressure cooker with a scenario, a real classic SJT setup. So imagine this. You're the junior doctor on the team, you've been involved in a procedure, and later that day, the patient has an unexpected bleed. They have to go back to theater, urgently.
Yep.
And you have this sinking feeling that the complication might be linked to a step you performed. It might not be your fault, it could be a system issue, a known risk, whatever. But the patient's family is there, now, and they're asking questions. The full investigation isn't for another month. So what's your immediate priority? Right then and there. Do you wait, or do you act?
And that is a brutal scenario. It's brutal because your human instinct, your gut feeling, is to just pause, to wait until you have all the facts, until you're certain whose fault it was.
Of course.
But the professional standard, it completely overrides that. The GMC demands you address the harm or even the distress as soon as you possibly can. It's about being immediately open, even when everything is still uncertain.
So if we had to boil this entire huge topic down into one core truth for the exam, what would you say that is?
The one core truth, I think, is this. When harm or distress happens, or even could happen, you must be immediately open and honest with the patient. And just as importantly, you have to be promptly honest with your colleagues and your organization to make sure everyone learns from it.
That word, immediately. That's the bit that trips people up. Why is this tested so much in the SJT? What do we really need to focus on?
Well, at the end of the day, it's fundamental to being a good doctor. First, it's a non-negotiable duty in good medical practice. You just have to do it. And second, in the NHS, it is the absolute engine of our learning culture. Reporting things early, even the near misses, means we catch system failures fast.
And stop the same mistake from happening to the next patient.
Exactly.
So if the SJT is all about rewarding that kind of systemic thinking, what's the absolute biggest trap we need to avoid?
The biggest trap is delay. It's always delay. Any option that involves waiting for a manager, waiting for the full investigation, or worse, just ignoring it, that will score terribly. It's seen as prolonging the patient's distress, it damages trust, and it just stops the organization from learning.
Okay, let's unpack the structure of this then. The GMC talks about a dual duty. Can you just walk us through what those two sides of the coin are?
Sure, it's basically a two-pronged approach. First, you have the duty to the patient. This is all about immediate transparency, compassion. When something goes wrong, you have to tell the patient or their family what happened. You have to give a genuine apology, clear information, and offer some kind of remedy or support to help. And you've got to explain what the likely short and long-term effects are.
Okay, so that's one side. What's the other?
The other is the duty to the organization. And this is all about making the whole system better. It means you're open with your colleagues, your bosses, you take part in reviews, you help with investigations, and this is key. You actively support other people who are trying to do the same. So it's honesty at the bedside, but also honesty in the department meeting.
I think we need to pause on that word apology, because that's where the fear really kicks in for junior doctors, isn't it? We know we should apologize, but there's this huge fear that saying I'm sorry means you're admitting legal fault, and that could damage your career. How do you deal with that in an exam?
That is the crucial question, and you have to get this right. In the UK, we have legislation like the Compensation Act that specifically clarifies that offering an apology is not an admission of legal liability in a negligence claim.
Right.
The SJT is testing your professional duty, and that duty mandates an apology. Saying sorry shows insight, it shows compassion, that always scores highly. Refusing to apologize because you're scared of lawyers, that's seen as a serious professional failing.
That clarity is so important. So when the pressure is on, we need a clear framework, a step-by-step guide. What are the strongest actions to take when an adverse event happens?
Okay, let's build a template. The priorities are always safety and reporting. 1, safety first. Do whatever you need to do immediately to make things right for the patient, to manage the complication.
Okay, clinical priority first.
Always. 2, identify the lead. Make sure the most appropriate person, usually the consultant in charge, is taking responsibility for the conversation. If that isn't you, your job is to support them.
Right, don't go it alone.
Exactly. 3, speak as soon as possible. Go to the patient or family right away. Be honest about what you know and be honest about what you don't know yet. You cannot wait for the final report.
Got it.
4, Personalized candor. This means giving a genuine, sincere apology. Something like, I am so sorry that this has happened to you. Share the facts you have and offer support, which has to include a specific person they can contact with more questions. 5, report internally and nationally. This is huge. You report the incident or near miss straight away using your hospital's policy. Usually that means the LFPSE system. And this comes up a lot if it's a drug reaction or a faulty device. You must use the UK-wide yellow card scheme to report it to the MHRA.
The MHRA, okay? And the last step.
6, document. You must record the details of the discussion, the fact you apologized, and the support you offered right there in the patient's clinical record.
That is a brilliant structure. So to lock that in, let's use a mnemonic. Let's go with CANDOUR.
Perfect. Let's run through it. This is your mental checklist. C is for communicate. Tell the patient as soon as possible.
A is for apologize. And remember, that doesn't mean legal liability.
N is for near misses. You need to use your professional judgment about whether to disclose those.
D is for document. Record the discussion in the notes.
O is for offer support. That could be a remedy or just a clear contact point.
U is for understand.
Yeah.
So actually checking that the patient has understood what you've told them.
Yes. And finally, R is for report. Follow your organization's policy for system-wide learning.
I like that. And for a visual cue, I always think of it like this. Imagine your professional record is a clean, white slate. The duty of candor is how you keep it transparent and smudge-free. You report and document the facts immediately, no matter how difficult.
That's a great way to think about it. Okay, let's get into some specific scenario patterns the SJT uses to test this.
Let's do it.
First one, system error versus personal error. The exam loves this. It's testing if you can be accountable without, sabotaging yourself.
So if a piece of equipment failed or something.
Exactly. If the mistake was clearly a systemic failure, you still apologize that the harm occurred. You say, I am sorry this happened to you, but you also clarify the underlying reason as honestly as you can, and you make sure the lead clinician is involved.
So you don't have to sort of fall on your own sword for something that wasn't actually your fault.
You absolutely don't. The SJT rewards systemic thinking. It does not want the junior doctor who takes all the blame for a service failure. It wants you to show insight and report the system issue so it gets fixed.
Okay, what about near misses? An error almost happened but didn't cause any harm. Do we still have to tell the patient?
This is all about professional judgment. It's more nuanced. You have to tell the patient if that information is important for their ongoing care or if hiding it could damage their trust in the team.
But what if it's really minor?
Well, if it's a very minor event that definitely won't cause harm or distress, the safest move is often to get advice from a senior colleague before you say anything. The goal is to avoid causing unnecessary anxiety.
Pattern 3. The patient who refuses information. You try to be open, and they say, I just don't want to know.
This tests respect for autonomy. You have to respect their wishes, but you can't just walk away. You should gently try to find out why they're refusing and explain the possible consequences of not knowing. Then, you document their refusal very clearly and make it explicit that they can change their mind at any time.
And what's the last pattern?
This one is more of a senior pattern. Management responsibility. It's about fostering that learning culture. If you're in a management role or you see a senior colleague in this situation, you have a duty to make sure systems for audit and review exist. And crucially, you have to protect staff who raise concerns from being unfairly criticized. You can't have a culture of candor if people are afraid of speaking up.
Okay, let's flip this around. Let's talk about the classic trap answers. The options that seem tempting to panic, but will always swing poorly.
Right. Every one of these violates one of the core principles. Number 1, delaying the discussion. It's a natural fear response, but it breaks the rule about relieving patient distress as soon as possible.
Trap number 2, ignoring the incident.
That gets penalized so heavily. It violates your duty to protect future patients. You're blocking any chance for the organization to learn.
Okay, what's next?
Trap 3, breach of confidentiality after a patient has died. You have to be open with the bereaved family, that's mandatory, but you still have to respect any known wishes the patient had about sharing their information.
Right. And trap 4.
Taking personal responsibility for everything. Insight is good, but the GMC doesn't expect you to take personal blame for a system failure or someone else's mistake. That's confusing compassion with liability.
And the final trap, number 5.
Telling a colleague to keep quiet. This is a huge red flag. You must never, ever try to cover something up or stop someone else from raising a concern. A fitness to practice panel would view that as one of the most serious things you could do.
Let's finish with some really quick rapid-fire examples. If X happens, you do Y.
Okay. First one. You notice a serious suspected adverse drug reaction.
You report it straight away to the MHRA using the yellow card scheme, and you tell the patient.
Perfect. Second, a patient has died following an adverse event.
You have to convey the information compassionately to their family, offer bereavement support immediately, and give them a single point of contact.
Absolutely. And last one, you are discouraged or even prevented from reporting an incident by a manager.
Then you have to immediately raise a formal concern, following the GMC's guidance on raising and acting on concerns.
Exactly.
Okay, this has been so helpful. To summarize this entire deep dive, let's do the 3 most critical takeaways for the SJT. I'll start. Number 1, candor is mandatory and it's immediate. It means giving a personalized apology and an honest explanation of what you know right now.
2, an apology is a professional duty. It shows insight. It is not an admission of legal liability, so don't let fear stop you from being a compassionate doctor.
And third, the duty of candor is dual. It's about honesty with the patient, yes, but it's also about activating that learning culture by reporting everything internally through systems like LFPSE and nationally with the yellow card scheme.
And maybe just one final thought. Remember that real candor actually starts long before any mistake is made. Honesty isn't just about fixing things when they go wrong. It's about informed decision-making from the very start. It's about discussing risks properly during the consent process.
That's a brilliant point. Keep these principles at the front of your mind, and you'll be the safest, most professional doctor you can be, especially when the exam pressure hits. If you do need more high-yield structured revision to help you score highly in the MSRA SJT, you can check out pastthemsra.com. We really hope this deep dive helps you feel much more confident and prepared.